The evidence pyramid provides a visual representation of the levels of evidence assigned to clinical studies, based on their design quality and applicability to patient care. As a clinician, you make treatment decisions every day. Because the goal is to provide your patients with the best treatment available, these decisions should always begin and end with the patient. Your patient may have a complaint, or report symptoms, or may have questions or concerns, or perhaps you note certain clinical signs. Whatever the source, this concern is turned into an appropriate clinical question. To answer the question, you search for the best evidence and determine whether that evidence is applicable to your situation. Then, together with the patient, you make a sound treatment decision. But how does one determine the best evidence? The evidence pyramid is a guide that can be used to evaluate the strength of the research evidence. You may have seen this or other versions of this pyramid. This version focuses on human trials and addresses each of the types of research one might consider when answering a clinical question. The weakest level of evidence is at the bottom: background information and expert opinion. This might include, for example, a textbook on the clinical topic or the opinion of a specialist. While this information may provide some background or a starting point, the strength of such evidence is low. For example, there is usually a lag of 3 or more years between the time a textbook is written and the time it is published, so the information is likely to be out of date. And the expert's opinion may be based solely on his or her own clinical experience and not on the research literature. The next 2 levels of evidence come from observational studies, that is, research in which one observes naturally occurring groups. There is no experimental manipulation and no assignment to treatment conditions. The case report is a description of an individual case, and the case series represents an extension of the case report to more than one patient. As with the case report, the case series is descriptive only. There is no comparison group. In case-controlled studies, patients are selected based on an outcome of interest, such as cancer, and then compared to a group of patients who do not exhibit the outcome, to see if there are any differences between the 2 groups in past exposure to potential explanatory factors. The patients with the outcome are referred to as cases, and the comparison group is referred to as controls, although these individuals do not represent a true control group. The case control is a retrospective design because the outcome has already occurred. In a cohort study, patients are selected based on exposure to some possible explanatory factor and are then compared to patients not exposed to see if there are any differences in the outcome of interest. This type of study is generally prospective, following patients forward in time, but it can also be retrospective. In a retrospective cohort study, patients are still selected based on exposure status, but then past outcomes are reconstructed from historical records. Case control and cohort designs are referred to as observational studies because there is no intervention. Patients are selected for the characteristic of interest, that is, exposure or outcome, and then compared to similar individuals without the characteristic. The difference between cohort and case control studies is that patients are selected on the basis of exposure to some potential explanatory factor in a cohort study, whereas they are selected based on some outcome in a case-controlled study. It is important to note that although these studies appear in the bottom portion of the evidence pyramid, they provide valuable information because they allow researchers to assess potential relationships in situations in which experiments are not possible, and they often generate additional questions that can be further explored in an experimental design. The next level of evidence is the randomized control trial, or RCT. This is a true experimental design, as there is an intervention in which patients are assigned to treatment groups. In the most basic RCT, patients are randomly assigned to either the treatment or control group, and then followed for a period of time to see if the intervention has an effect on the outcome of interest. Note that RCTs are designed to establish causal relationships. The top 3 levels of the evidence pyramid involve an interrogation of the literature. The research designs involve establishing PICO or other criteria for the literature to be reviewed. One can think of these designs as research in which the data are collected on articles rather than on individual patients. The difference between critically appraised articles and critically appraised topics is that the former only examine one article, while the latter assess several articles on the same topic. The systematic review holds the place of honor at the top of the evidence pyramid. As the name suggests, a systematic review involves a systematic or methodical search for all literature on a given topic. Contained within this category is the meta-analysis, an even stricter review that uses statistical methods to summarize what is known about the topic. The top tiers of the evidence pyramid consist of filtered information, in that the literature has been critically appraised. Information that has not been critically reviewed is considered to be unfiltered. To summarize, the evidence pyramid provides a guide that can be used to evaluate the strength of evidence related to a clinical question. While the strongest evidence is found at the top of the pyramid, these levels of evidence do not exist for many clinical questions, so one may need to move down the pyramid to find information relevant to the topic of interest.